Thank you. Thank you, everybody, for making the time, and thank you to VSee for putting together a really nice conference. Certainly appreciate those of you who have stuck around here to the end. Given that it's the second day and this is the last group session, how many of you are committed or interested in the field of psychiatry? I'd imagine there's got to be a good reason you're sticking around through all this. So more than about half the folks who are here. So what I want to do is spend a little bit of time talking about our experience building programs in telepsychiatry that have been sustainable, that have grown over the years, that haven't just been experiments or pilots. Jen touched on a lot of really great points, so I'll skip over some of the content that's redundant and leave more time for discussion otherwise. Just a quick kind of overview of our organization. We provide telepsychiatry services using MDs and nurse practitioners across the country. We are employing about 300 psychiatrists and nurse practitioners today, treating about 150,000 patients a year on our program. These are the states we cover. This is all our stuff. We primarily focus on a Medicaid population, so a bit more of a complex population clinically, usually comorbid with other illnesses. And so for us, we have found it to be really important to integrate telepsychiatry into care settings where patients are receiving other services, case management services, nursing services, et cetera. Now that's the model that works for the population we're targeting. Jen's population in skilled nursing is different. The at-home cash pay population is different. And hopefully the theme that you're seeing emerge here is the importance of understanding your patient population and building the telemedicine model that really integrates well into where they are, meet the patients where they are. So a little bit about how we believe you build sustainable programs. You really have to start by thinking about all the stakeholders involved in a telemedicine program. You have the clinicians, in our case, the prescribers, but in many cases, therapists or psychologists. You have the patients, understanding where they are and building a program that meets patients where they are clinically and geographically. You have other care team members involved in patient care, so it could be primary care, it could be psychologists, it could be case management staff that you have to keep in mind, and then of course you have to keep in mind the payer. And so the model that we're about to talk through is one that really thinks about all of these different stakeholders and makes sure that we're able to build a program that addresses the needs of all of them. And what we find is that when you do this, when you address the needs of all the stakeholders, you can really see programs grow. This is a chart that demonstrates how many hours of care per week we've been delivering since 2012 when we got the business going. And really what you see here are two stories. One, it takes a while to learn all of this, and that's why we're here on the stage, hopefully sharing with you guys some learnings so that you guys can start, do I have a laser pointer here? No, where it starts getting fun. Right? Not where it was flat for a few years. But you've got to learn what's important to patients and how business models work and how payers are going to work with you to really start to take off. So we'll talk about that. Going through the different stakeholders here, we talked about the facilities, we talked about the providers. Jen mentioned, what number did you say we had? 50% of 100,000, so our numbers align, right? We count about 45,000 providers in the community, 80 million patients potentially in need of psychiatric services. So how do we think about the benefits to each one of these stakeholders in building a telemedicine program? Well, first and foremost is the patient. So how do you build a program that's patient-centric? A lot of it is understanding specifically where the patients are. For us, with the Medicaid population, we don't try to bring a new model of care to patients. These patients are often already being managed inside of community mental health centers by federally qualified health centers. And so what we're doing is we're adding our programs inside of the workflows that exist at these clinics. And when you do that and you become one system of care, not yet another mode of care that patients have to chase down, you see really great responses from patients. We see that 85% of our patients we see the first time come back for follow-up visits. We see that the average patient engages with us over 5 appointments, but that a big chunk of them have gone into their 15th or greater appointment. And this is really a demonstration of really getting smart around building a model that's patient-centric, meeting the patients where they are. On the provider side of things, well, how do you build a program that is meaningfully incentivized for providers? Telemedicine is great. I think, we talk about the provider supply. Jen made a really good point around how the market is undersupplied in a broad sense. But telemedicine offers providers something that they often can't get in traditional practice: flexibility, the ability to work from home, the ability to reach underserved populations without either long commutes or immersing themselves in communities that may be challenging. And when you put all of that together, what you see is providers truly are really excited about telemedicine. We today find that a provider will dip their toes in the water by working with us, call it 4 hours a week or 8 hours a week. But as they get started and they learn more about how it works, they want to spend more time. They want to ramp up. And you see providers on average working with us grow the amount of time they spend delivering care via telemedicine 11% every month for the first 2 years, where they start out doing something like a few hours a week, and then pretty soon they're doing telepsychiatry full-time. So it's really truth in action here around if you build the programs that are thoughtful around solving for what providers want, you can do something that really creates engagement for them. For the payers, right? Payers who are covering these services, traditionally, if you go back 4 or 5 years ago, payers were pretty reluctant to reimburse for telemedicine services. Now, through the really great work of the American Telemedicine Association, I see Dr. Yellowlee's in the audience, there's been a collective advocacy effort to move the needle on reimbursement requiring payers to cover telemedicine services in many different settings, outside of rural only. And that's been driven by a lot of the clinical data that has been driving the advancement of telemedicine. All of this says, in short, that treating a patient via telemedicine on both a diagnosis basis and an outcomes basis is no different than treating that patient in person. And as that data has seeped in and as payers have started to look at their own internal data that has reconciled with this, they've gotten more comfortable supporting telemedicine. And now we're kind of on the other side of the curve where payers are actually wanting to pay more for telemedicine. We have relationships with United Healthcare, with Molina, with Centene, the Medicaid plans, which are kind of our wheelhouse, that are all saying, we'll actually pay you more to do these telemedicine services than an in-person service because you use it to go reach these patients who are otherwise not getting treatment. And that's all this data is saying. So a little bit around technology. It used to be the case that you had to invest a lot to get programs up and running, but through the pioneering work of VSee and other applications that are out there now, you're able to stand up a telemedicine program for a fraction of the cost that you used to. You no longer have to go buy a Polycom system or anything like that. Our conference sponsor here can get you guys set up for really incremental costs. So this notion of investing a lot in technology to get a telepsychiatry program up and running is thinking from a few years ago. And if you're here, you're here because you realize that. One reimbursement piece, Jen, you touched on this briefly. When you're working with government payers on delivering telemedicine services, without any special negotiation, you're actually able to achieve better reimbursement than in-person services. And that's driven by what's known as the originating site fee. It's billed as Q3014. That code is used per session and paid anywhere from $15 to $25 per session to facilitate the delivery of telemedicine. And clinics, facilities, the skilled nursing organizations that Jen work with can use this to get reimbursed an extra $75, $100 per hour depending on provider efficiency, which are economics that start to make telemedicine really attractive. You start to pay back for VSee within a few hours of care simply by catching this Q code. All of that aside, the most important thing we've learned in 7 years of doing telemedicine is that you can't underrate how important the clinical match is between the provider and the patients. And really that's where we've made our reputation. I think that's the most important thing I can advise to you all as you're thinking about setting up your programs. Work hard to understand what it is the patients need clinically. Work hard to understand the setting that the patients are in, the other resources they have, and make sure that the providers that are on the other side of that equation are well suited to work in those settings. The programs that we find that disintegrate, that kind of fall apart pretty quickly, are ones that aren't thoughtful about understanding the patient and the provider first, and not going through a thorough process to match the right provider to the right clinical setting. But when you do that, you end up with the hockey stick type curve that we saw earlier. There are a few steps required, manufacturing to make sure it happens. This is just a supply chain slide, but take your time. I think I'm done. Yeah, testimonials, and that's it. So we'll take questions now.
Thank you. That was a great talk. Any questions?
Thank you. That was excellent. Have you ever tried risk-based payment models or capitated models to prevent hospitalizations and things like that for your extreme mental health patients?
Yeah, so great question. The exciting thing about behavioral health is just from a macro perspective, it is not being adequately reimbursed within our healthcare economy. And what payers are starting to realize is their underinvestment in behavioral health is costing them dollars elsewhere in the form of hospitalizations and in the form of medical costs, right? You can't manage the diabetes without managing the anxiety first. What we are finding in our experience is payers are willing now to have that conversation. Our risk-based contracts focus more on HEDIS measures that payers are being held accountable for, things like follow-up after hospitalization, things like patient engagement post-discharge. And there we're able to negotiate new reimbursement models that are a little different. We're not quite at capitation yet, but this is the step in that direction.
What about working with the primary care physician? How do you coordinate your care with them?
I was in an Uber on the way here from the airport, and I was on the phone with United Healthcare about exactly that their primary care providers are seeing behavioral health at a rate that's hard for them to manage. And the question that payers have now is, how do we integrate behavioral into primary care? The truth is, it goes back to one of these slides, right? Like, understand what the primary care provider is able to do today and bring the resources in to complement them. The goal is not to replace the primary care provider. The goal is to supplement them and help in where primary care providers can't reach all the way to the most complex behavioral health illnesses. So you have to be specific around understanding what the clinical setting is from a primary care perspective that you're diving into, but there's a lot of need there, and payers are welcoming these models with open arms.
So if I got correctly, you said you're just covering the Medicaid population?
Primarily our work is Medicaid. I'd say about 90%, but we do commercial and Medicare as well.
So how it's basically you're doing in more remote areas, not in urban areas, is that right?
Medicaid actually doesn't have a rural area restriction like the Medicare patients do. So I'd say about 65% of our patients are actually in urban settings, places like Southside Chicago, Compton in Los Angeles, the Bronx in New York. That's actually where we see a lot of Medicaid need for behavioral health.
I don't have a question, I just have a comment. Thank you for taking care of that patient population. It's not easy, and you're the only person in this entire conference that is taking care of our vulnerable Medicaid patients. So thank you so much.
It's not us, it's our providers, but thank you. If you just email me or Lauren, we'll just send you this deck. That's no problem.
But all the slides we do make available for all the attendees. Okay. Again, thank you so much. Really, congratulations. But this is, again, on top of all his success, for a lot of aspiring entrepreneurs, definitely talk with him. He's someone who actually been there, done that, and being super successful. And thank you so much.
Thank you.
Okay, thank you.